Thank you. Welcome everybody to the Smilia Masterclass offered by Suez Canal University and ACTS. The first talk of this afternoon is applied anatomy. Anatomy is important for surgeons because that is what is underpinning what we do. So this venture started 2 years ago when ACTS partnered with the Egyptian Society on the 25th anniversary of the Egyptian Society for Cardiothoracic Surgery. Last time we did it live face-to-face in Suez Canal University, but this time it's all in the virtual world. So what I'll try to do is to take you through the basics of the anatomy and the applied anatomies of how that works when we are doing emergencies and applications of incision and procedure. For the senior surgeons out there, some of this may be fundamental, but for the trainees and the future surgeons, it is important. That's why we felt we need to include this. So the chest is a dynamic structure. I call it a balloon inside a box. That's exactly what it is. You have two balloons, which are the lungs, and you have the ribs cage, the sternum, and the muscles attached to that. And you have the pump and the various tubes, which is the heart and the great vessels in esophagus and trachea. So it's a dynamic structure because the ribs move and you have the bucket handle movement of the ribs going up and down, and that brings the sternum forward. So all of that has a bearing in the patient's recovery from surgery, but more importantly, in terms of the implications of the incision, the pain, and perioperative recovery. So you have the vertebra in the back, from which you have 12 ribs, of which some come and attach to the sternum through the costal cartilage, and some of them are attached to the costal arch at the bottom. The manubrium is in the middle, you have the clavicle joint, and then you have the manubrio-sternal joint. And all of this has a bearing when we are doing surgical procedures, when we are trying to close the patient up. And as you can see, you have the lungs on both sides, as well as what we call as intrathoracic abdominal organs, which on the right side, you have the liver, on the left side, you have spleen. This all bears importance when you're dealing with trauma, particularly with stabs and things. So attached to the rib cage, we have muscles of respiration, because perioperatively respiration becomes utmost important. My colleague who's going to follow me, Amar, is going to give all sorts of medications which make the breathing difficult, and the patient has to recover. So they need to have a good muscle mass, and it is important you understand what are the muscles of respiration. So you have active muscles which incorporate the intercostals and the diaphragm, as well as the abdominal muscles. Then you have accessory muscles, which include the sternocleidomastoid and the strap muscles. And all of this enable the patient to draw breath and keep breathing whilst we are all alive. And if you take it away, the next layer is the pleura. So we've taken the chest wall away with all the muscles, and the next layer is the pleural, encompassing both lungs as well as the pericardium. So you can see the top shows the thoracic inlet or outlet, depending on how you want to call it, which has the great vessels leaving the thorax. And then you have the visceral and parietal pleura encasing the lungs. On the right side, you have the 3 lobes, and the left side, you have 2. And in between, you have the pericardium encasing the heart. So you have the great vessels, the SVC coming in, and the IVC, which is hidden here. And you have the confluence of the brachiocephalics to form the SVC. The trachea is hidden there, the aortic arch giving rise to the blood vessels. All of this have an importance when we are doing surgery, particularly mediastinal surgery as thoracic surgeon, and for the cardiac colleagues to look after the nerves. So you have the phrenic nerves running on both sides on the pericardium, and you have the recurrent laryngeal nerves, which come along the vagus, loop around and go back. On the right side, it loops around the arch, on the left side, on the right subclavian. Sorry, on the right side, on the subclavian. On the right side, we have 3 lobes, upper, middle, and lower. And the left, you have upper and lower. The lingular is a vestigial remnant of the middle lobe. They are not equally distributed. The middle lobe and the lingular account for about 1/5 of the volume, and upper and lower have more volume. We also have the fissures which define the lobes, and these have taken a new meaning in present day, particularly when it comes to talking about long volume reduction surgery later today, because Previously, fissures were just demarcations between lungs. So we have the oblique fissure, which separates the upper and the lower on both sides, and then the horizontal fissure, which separates the upper lobe from the middle lobe. The vessels are hidden in the fissures. When you're doing a lobectomy, air leak is from the fissures. So it is important. And the fissures may be complete or they may be incomplete, which may make surgeons' lives easy or difficult. And each lung then is subdivided into bronchopulmonary segment. Again, this takes more bearing today's world when we are talking about sublobar resections and anatomical segmentectomies with a view to conserving lung. So we have 10 segments on the right and 9 segments on the left because the heart is towards the left side. And the mediastinum, the last element of the thoracic cavity is the mediastinum. So you can use various classifications. You can go to the classical anatomical classification, which is superior mediastinum, which is above the angle of Ludwig, the middle mediastinum, and posterior mediastinum, and anterior mediastinum, which is everything in front of the pericardium. Or you could use the Shields classification, which is paravertebral sulcus, middle mediastinum, and anterior mediastinum. The posterior mediastinum or the paravertebral sulcus has your esophagus, the trachea is in front of it, and you will have all the spinal nerves coming out. So any tumor may be found in the paravertebral sulci. And this is in cross section because it demonstrates the intimate interlinking of the vasculature with the bronchus. So you have the bronchus which comes in and divides, then you have the blood vessels. On this cut, you see the veins going in, so the PA branching into the right and left, and the veins come. So this has an importance both in terms of anatomical lung resections, because you need to dissect them individually without compromising the other. But more importantly, when you're talking in terms of a trauma setting, which we'll see towards the end of the day. So if you have a stab which goes through, you're causing confluence of pipes which carry blood with pipes which carry air, which causes air embolism and which can be life-threatening. So the respiratory tree is formed of the trachea, which has C-shaped cartilages with the trachealis muscle in the back, which divides into the two main bronchi. The right is shorter, right main is shorter than the left. The left then divides at the secondary carina into upper and lower. The right gives off to the upper lobe bronchus and then subsequently middle and lower. And this again has a bearing when it comes to anesthesia, because my colleagues, when they put the double lumen tube, are going to have difficult strategy for both sides. And likewise, when it comes to operating, most surgeons would operate with a left-sided double lumen tube for any operation except doing left pneumonectomy. And you have to bear that the upper lobe is a shorter takeoff on the right side, and in about 4%, it can come straight off the trachea in what is called a tracheal bronchus or pig bronchus, which is an anatomical challenge for the surgeon, but more importantly for the anesthetist if they're going to place a right-sided double lumen tube. So there are fundamental differences between the two. The right is more vertical than the left. Left goes flat under the aortic arch, and the right upper lobe bronchus arises more proximally, like I've said. The right pulmonary artery passes anterior to the major bronchi and is longer than the left PA. The left arches over the left main and upper lobe bronchus, so it is called the eparterial bronchus. And the hilum, again, is different when we're talking about anatomical resections of taking the vein, artery, and vessels. The PA is found at the junction of the SVC and azygos on the right. The veins are just below but anterior to the artery, and the artery. So the configuration is vein, artery, and bronchus closer to the hilum. And on the left side, the vein is still anterior, but the bronchus is interposed between the PA, so it is a VBA configuration. So you have to take this into consideration when you're doing a lobectomy, more so when you're doing a Bat's lobectomy and you're going to be working from a distance. It also is important because we try to avoid errors, but sometimes if you're not careful, you can take the vein and the bronchus or the artery and the bronchus together. This has happened in lobectomies. Then you convert and you have to reconstruct everything. So that is important to know the anatomy. We've talked about the trachea. The adult trachea is quite long and we can take up to half or a third without any difficulty and reconstruct. So tracheal surgery is a bespoke subspecialty within surgery. My colleague, Mr. Kalkut, has a special interest. I have an interest in tracheal surgery and bronchoplastic resections. But once you take more than 6 centimeters, you may have to do release maneuvers. Tracheal surgery per se is easy because you're joining two tubes. But what makes it challenging is the recurrent laryngeal nerves which run just along that. But more importantly, the working with the anesthetist in swapping the the tubes from endotracheal to transtracheal ventilation so that we offer a smooth transition in the reconstruction. So there are some nerves within the thoracic cavity and we have to be mindful of them. The most important one is the phrenic nerve, because if that gets paralyzed, the patient's not going to breathe well. So these run along the pericardium. They are liable to injury when you're doing superior mediastinal tumors, or if you're not careful when you're doing release maneuvers with adhesions for lung resections. The vagus is posterior to the hilum and it gives rise to the recurrent laryngeal nerves. Like I said earlier, the right side hooks around the subclavian vein and the left around the aortic arch. On the back, we have the sympathetic chain, which comes into play if we are doing sympathectomy for hyperhidrosis or facial flushing, and more importantly these days for cardiac arrhythmias and refractory angina when all other things fail. And the brachial plexus are found in the thoracic inlet. So if you're operating on the superior mediastinum for the superior sulcus tumor or Pancoast tumor, or even doing a simple thing like bulectomy, pleurectomy, if you're not careful, you can cause damage to the lower trunk of the brachial plexus. So you have to bear in mind those structures. The thoracic duct is an interesting one, which comes from the abdomen carrying the chyle to empty into the left subclavian vein. And that crosses the midline. So when you're dissecting the mediastinum, when you're removing your lymph nodes in the subcarinal node or in station 8, you have to be careful you don't injure it. More so if you're doing surgery like radical mesothelioma, where resections where the pleura is stripped completely, you always have to be mindful and you may have to deal with it proactively by ligating it rather than wait for chyle leak to start and then fix it. There are lots of lymph nodes, and these are paramount importance when we're talking about diagnosis for mediastinal lymphadenopathy, from simple things like tuberculosis, sarcoidosis, or lymphoma, or lung cancer. But more importantly, when it comes to staging of lung cancer, so we have to sample the 3 stations pertaining to the node as advised by the ESTS guidelines, which is 2R, 4R, and 7 for the right upper lobe, 5, 6, 7 for the left, and so on and so forth. So one has to map the lymph glands and sample them either with a endobronchial ultrasound or cervical mediastinoscopy, but more importantly to complete resection when we do surgery. The Leicester practice is to do a complete lymphadenectomy, but there are units which would do sampling that is varied across the country. Now, putting all of this in context, so that's the basic anatomy. So you can then divide the chest as peripheral chest and central chest when it comes to injuries. So peripheral chest is just lung, parenchyma, great vessels, and diaphragm. Central chest is the heart and the vital structure. So a stab to these may need to be managed differently. We need to be prepared for that. We need to think of what structures are at risk of an injury. Intercostal drain is a simple procedure, but it is one thing which our juniors do constantly. So the key is always stay above the rib. It's blunt dissection. It is in the triangle of safety, and you get a good sized tube in. Pericardiocentesis mostly is not done these days because it's all part of the ATLS triage and it's done by ED team, but it's by advancing a needle aimed at the left shoulder tip at an angle, which will give you pericardiocentesis. There's an illustration to show how that's done. Subxiphoid window, a small neck below the xiphy process, and with a finger sweep, you can pick the pericardium and you can do a window. And moving along, that's your standard thoracotomy. Patient is in the right lateral position. You make an incision. You divide the latissimus dorsi serratus anterior, maybe spared, maybe resected, resected and the intercostals are stripped away, and that gives you a big incision. You could then sling your vessels and do whatever you want to do. With VATS, those become small. It is more of blunt dissection and you use a protector, but still then you have to be careful about the neurovascular bundle. A simple wedge is a cake slice with a cherry in the middle operation. A lobectomy is a total lobe with all the structures which we talked about. Pneumonectomy is the whole thing, and segmental resection we talked about. Sleeve resection, wherein the tumor is in a junction where you can take the main part of it and re-anastomose. So this is a right upper lobe tumor where the right upper lobe is removed and we re-anastomose it as we see in the slide. A quick intro into the anterior thoracotomy. It is done on the left side, fourth or the fifth space that gives you access to the pericardium. We'll discuss these in detail later, and then that's the clamshell. So with that, I'm going to stop